Hello, and welcome back to another episode of Straight Up With Steph. Today, we are talking all about osteoporosis and bone health. If you're anything like how I used to think that osteoporosis was for our little old ladies. Not the case. Actually, we need to start really thinking about our bone health as early as our 30s, which is way earlier than I ever thought. And osteoporosis affects other people other than our little old ladies. It affects young people, even in their 20s, and it's starting to affect more and more men. In fact, 1 in 4 men will develop osteoporosis. Today, I decided to bring in Kristin. She's a fellow hygienist, but she also is an educator on anything oral systemic. And today, I'm picking her brain about osteoporosis. She's actually got a personal experience, which I always think the people that have these personal experiences have the strongest message because they've lived it. So she'll share that with us today. We'll go over the risk factors of osteoporosis, also things that we can do now to start protecting our bones and our muscular health. And also, as dental clinicians, what we can start to look for with our patients, maybe some warning signs that can open up that door of communication with our patients. Just like a lot of things, when we're talking about screening, we in dentistry are excellent screeners. And so she tells us how we can start doing that. One thing that's a hot topic now are these GLP-1s like Ozempic. And I was curious how that can affect our muscular health and our bones. And she talks to us about that today, too. This is a really important conversation, especially considering how early osteoporosis can happen to us and how common it is in our population. I hope you enjoy today's conversation with Kristin. Hey, it's Steph, and welcome to the Straight Up with Steph podcast, where we have real discussions around health and life and just trying to be better at both. Hello, Kristin. How are you today?
I'm so good. Thank you. Thanks for having me here. I'm really excited about this.
Me too. I just cannot wait to hear what you have to say about osteoporosis. But before we get into all of that, just tell us a little bit about who you are and how you became known as the PHRDH.
All righty. Well, in 2017, I first should tell you that this was not in my plans. My plans when I became a dental hygienist were to work clinically for, if possible, 30 years and then hang up the old scalers and be done. I am currently still clinical at 32 years. So things have definitely changed in my life, and I am a super big God person. He is controlling this and moving me in a way that I've never, ever thought, like I'm here today with you. So it started really, I would say, around 2017. I had my daughter who was in high school, and she started struggling with some health issues. I started kind of deeper diving, having people talk to me. Some of the current CEs that I had been going to in dentistry were actually starting to focus on systemic, and it was exciting me. And so 2017 was kind of like my really renewal of my hygiene and moving me into systemic health. So I started to take that on. I had actually been pre-diagnosed in my early 30s with a possible autoimmune, pretty severe one. So I always had that in, like, I need to take care of myself, but I was a busy, busy mom and I work. Then in 2019, I had actually came in contact. I wanted really natural products, and I came in contact with Arm & Hammer Oral Care. And they had been talking about, I had been talking about baking soda for a long time to my patients as a completely natural way to help neutralize pH, because I had listened to Dr. Brian Novi and he had talked about pH, and I wanted to make sure I protected my patients, and I was learning more and more about pH. So I became a professional educator for them and started doing these like mini presentations. And in that, I started deeper diving into little more and more and more about pH and acid, and that it wasn't just about bacteria, that it was about the gut. It was about mental health. And so I was like open to all these things that I had started to see. And so in 2022, I actually had a lunch and learn presentation where the doctor said, "Why are you not speaking nationally?" And I'm like, "Well, I kind of like this." And he said, "No, you know so much more," because after my presentation, I would say, "If you want to stick around, I have a few extra tidbits." And so they were like, you know too much, you need to get out there. And so in 2022, I became the national speaker on pretty much oral systemic health. Not that I've moved away from pH, because I still love it. It's still a big part of everything. But I also call pH my pro health, because I really am right now super pro health. And I want to just encourage people for longevity, wellness, and things like that. So again, it's really where I never saw myself, never ever dreamed this is not what I ever wanted, but it is now what I'm doing, and I love, love, love it.
That's awesome. See, that's how it works. Cause I was like you. I thought I was going to be a full-time clinical hygienist until I was like 70 or something. And I certainly didn't expect myself to have an ergonomic business, but life takes us in these directions that we're passionate about. And I love what you were saying too about that you're pro health, because what I'm learning, and I've learned a lot over the past few years just about health, that a lot of the recommendations that we have are to prevent disease, like the bare minimum, right, to prevent disease, not necessarily to thrive in life or to be healthy or to really be the optimal us, which is what I'm interested in. It's like, yeah, I want to prevent disease, but I also want to like live my best life too. So, about osteoporosis, how did you become interested in this and its relation to dental health?
Yeah, so this is not a complete turn from pH, but again, I had this platform now of this pH, and I was diving deep into acid erosion, was started to broaden into like systemic health, realizing that it had so much more to play, especially with dry mouth, obstructive sleep. We're talking about gut health, IBS, all these things started to come in more and more and more. So again, that was my life path. But in 2019, at the same time I was doing this, between 2019 and 2023, my youngest child left home. I was over 50 years old. I was struggling with anxiety, depression, and I was in menopause. And I had no clue what that meant. I had no idea. And that is a huge passion of mine right now. But I was in some serious health concerns. And specifically, I had severe back pain. So I kept thinking, this has got to be the thing, is my back pain. I had seen everyone, chiropractors, physical therapists, everyone. They would manipulate me or get me stretches, and I would feel better for a couple of days. I'd go to work, feel horrible. And I was trying everything I could do. Also, I was doing a low inflammatory diet. I was trying to just live super, super clean. And I was struggling with gaining weight. I actually, at one point, thought I had cancer. I was really actually concerned, because I was just kind of melting away. And people were even saying to me, like, you're really thin. And I'd be like, I'm eating. And so my brother is a primary care physician. I also have a brother who's a spine surgeon, but it was my primary care physician brother that actually pulled me aside and said, I need you to get a DEXA scan. And I said, what is that? I have no idea what you're talking about. And he said, no, I think he had been to a continuing education course, and he had actually felt like he wanted me to do it. And I said, I'm going to do it just to prove you wrong, because you're my little brother, right? And I'm going to prove you wrong. So I went ahead and scheduled my DEXA scan. And I was like, this is going to be great. I'm going to prove him wrong. And sure enough, I came back with a severe osteoporosis diagnosis. And I'm only 54. And I was shocked. I had no idea. Seriously, it blew my mind away. Like, this is not anything I ever thought I would have. And so that's really the start of this whole journey now, that has now moved me into bone health, as I've started to like connect the dots. I'm a 1970s, I grew up in the 70s, and we did dot to dot. And a lot of people may not even know what dot to dot is, but in a book, if you got a dot to dot book, you'd open it up and it'd just be this dots all over. And until you started connecting the dots, then you would actually then see the picture. But you had to start connecting the dots. And I feel like that's what I'm doing. And I love it, is I'm a dot to dot girl. So I start to connect dots. And when I got this osteoporosis diagnosis in 2023, I started to dive deep, and I started to connect the things that were happening in my body and connecting them then with oral health. And then I was blown away that there is so much correlation, but very little education on this. Most dental professionals have no idea about osteoporosis and what we should be doing and the risk factors and how it associates with periodontal disease.
Wow, that's crazy. For those who don't know, what is a DEXA scan? What does it tell you?
Yeah. So the DEXA scan is actually the primary way of measuring bone health right now. It's the number one standard. Some people are critical of it because it is an x-ray that is read by someone that then says, oh, you're at this point. But the DEXA scan is the true measure of disease right now in the United States. So that's really where we have to go with how to be diagnosed for that.
Okay, and osteoporosis, what is it? What does it mean?
Osteoporosis is really interesting because it is actually called the silent killer or the silent disease. It's a silent killer in the sense that it definitely is something that kind of comes up and sneaks up on people that they have no idea. And that was me. I had absolutely no idea. But it is a progressive metabolic bone disease and it causes low bone mass. So the bones actually will have holes in them. And this then increases the risk of fragility and fractures, which is really, really important. So osteoporosis, that's really what it is. It's a systemic metabolic disease. Now, when we think about periodontal disease, it is not a metabolic disease, but it has high association with metabolic syndrome. So you kind of have to say which one causes which, because we know that the jaw is a big bone. And so if we're having systemic issues, could we also be having oral, obviously, issues with our jaw and our jawbone?
So, if someone has a diagnosis of osteoporosis, are they then more likely to suffer from like periodontal disease, or is this an issue when with dental implants? Like, could that affect them too?
Yeah, absolutely. So one of the things is periodontal disease and osteoporosis have very, very similar risk factors. The genetics is a huge part of it. And even, genetic testing, we're starting to do more and more of. There's a chance if somebody is high inflammatory, this could be an issue. Anybody that smokes, caffeine, alcohol, high stress is huge. Obviously, cortisol and hormones. Menopause is huge with estrogen. Also, men and testosterone, those lower amounts can. Any thyroid, insulin resistance, IBS, eating disorders, those are all can contribute to osteoporosis. And we see that also with periodontal disease. And then osteoporosis, also the PPIs and steroids, they can bring people into more of an osteoporosis risk. So a lot of those we see that there's possibility of a connection because the similar risk factors. So if we're looking at that with periodontal disease, could it be that someone actually has a systemic bone disease that is probably contributing to that? And that can definitely be a problem with implants. There's actually was an implant study done in 2024, and it was on the first and second dental implants, like the failure rate. And it came out to say that osteopenia, osteopenia is like you're not quite osteoporosis yet. But
Okay.
so osteopenia or porosis had significantly more implant failures. Now that was the word, significantly more, and especially in the maxilla. This was even higher than someone who has diabetes. So this is something that we just I don't think in dentistry we even understand where we can be a part in helping with this because again, the jawbone it's a large bone. It holds all of our teeth. There's pathogenic bacteria that we know causes inflammatory response. We have that to play with it along with if we're struggling with a metabolic bone disease, is it just going to progress even further? And many times our immune system is also compromised during this time because inflammatory diseases often weigh heavily on our immune system. I call it a large systemic load. It's like, how many people are carrying such a large systemic load that it just takes one thing to put them over the edge?
When I hear you talking about just all of the like connections that osteoporosis has, I just think a lot of people think of our bones as just like providing structure, right? And helping us stand up or sit up. But clearly, our bones do a lot more than that. So, what functions do the bones have that maybe we don't know about?
Many people don't know that our whole skeletal system rebuilds every 10 to 12 years. I had no idea about that. So every 10 to 12 years, we get like a whole new set of bones. So it's important, but the fact is, by the time we're 30, we get our peak amount of bone. So at 30 years old, that's really the baseline of we should be at the peak amount by the time we're 30. And from then on, we kind of are a little bit going downhill or keeping bone. So our bones protect, they're structural, but they also protect our organs. So it's super important for that. But one of the key things also is they store minerals. And so many people forget that calcium, phosphate, so many different minerals are actually stored in our bones. And then on top of that is the bone marrow, which sits right in the middle of the bone, and that provides blood and bone cells. So this is where we make all of our blood and bone cells, and those provide oxygen, they provide immune response, and they also help with blood clotting. So our bones are super, super important. And when we don't have bone health, it really affects every other organ, and every other organ affects our bone health. It's that bidirectional relationship, again, that we're seeing so much now.
And that's why it can affect pretty much any system that we
And
have, especially inflammatory conditions too. When I used to think of osteoporosis, I would just think of it as like a little old lady disease. And I'm learning that that is not the case. So, how common is osteoporosis? And maybe give us like some statistics about it that aren't commonly known.
yeah, I think people will be shocked by this because, again, I was completely shocked, and I've been a hygienist for 32 years. It is not an old woman's disease. In fact, this is where my passion lies, is to just educate, educate, educate so that we can get this out. But every 2 minutes, a bone will break because of somebody with osteoporosis. Every 2 minutes. Also, 1 out of every 2. So that's 50%. 1 out of every 2 women over 50 will fracture in their life. So you and I are sitting here, Stephanie, right now. And it's most likely I'm going to be the one that fractures because I already have severe osteoporosis. But the fact is 1 in 2. There is not a lot of diseases out there that is that big that people have no idea about. And then 1 in every 3, and I know this number is sneaking up to 1 in every 2, will have either osteopenia or porosis. And so again, this is something that we really have to think about, that when our patients are sitting in our chair, that if we have 4 women in the day, that at least 2 of those women are a possibility that they're going to be a high fracture risk some point in their life. And then 1 in every 4 men. So that's 25% of men. And that number is getting higher as we're starting to see testosterone drop, because testosterone is a huge part and estrogen are a huge part. So it's those hormones. And many men aren't doing a lot of lifting anymore. They're sitting at the computer, they're playing video games. We've got inflammatory diets. Any of those metabolic conditions, again, will play to osteoporosis. So I like to think about periodontal disease. And we all know periodontal disease right now is the most common inflammatory disease. I think the world doesn't always know that, but the statistic is that periodontal disease is one of the most common of all the inflammatory diseases. Now, if we think about that, so that's bone loss in our jaw. Could it actually be that it's systemic and we just didn't know it? And that's where that's kind of a big passion of mine, is that, again, this periodontal disease can actually be maybe an early sign of that. And we need to help prevent that, because 40% of people that have a major fracture, so 40% of people who have a major fracture will die in that following year.
I'm really glad that you brought that up. I was going to ask you about that because there is significant mortality risks that go along with this. And I heard something similar about women over 60 or something. If they fall and break a hip, I mean, it is likely that they will die from that. And I'm just like, are you serious? Like, that's
Oh,
crazy.
it's super scary. But if you think about it, because 1 in every 5 women will have 2 to 3 fractures before they're even diagnosed. Like, why is that happening? A couple of like a week ago with one of my patients, I just am now like the big osteoporosis like detector. I had a patient come in and I can spot people now. I mean, I know who they are. But I had a sweet person come in and when I'm going through the health history, which I'm super duper thorough with, she had said she had broken her ankle. And I always ask, so what did you do to break it? And she's like, I really wasn't doing anything weird. She said, it just was like I just stepped on it wrong. And I said, so you had surgery or whatever? Yeah, yeah. I said, did they ever check you for osteoporosis? And she goes, no, they never did. And I'm like, so the thing is, there's a chance that if you have somebody that's breaking bones, like I had someone just recently tell me that their 20-year-old just randomly broke her ankle. And I'm like, could that be a sign of someone that's having early signs of bone loss? Because a 20-year-old should not be just easily breaking a bone
Right.
unless there's something that's leading to that. Some of the common signs I would say to look out for also for osteoporosis is brittle nails, because that has to do with being able to get minerals and keep minerals. So brittle nails.
I literally just like started feeling my nail. I'm like, are they brittle? I don't know.
Yeah, brittle nails and then receding gums. Now, this is
Hmm.
crazy. This is really a hard one for me because I think as dental hygienists, our whole goal is to save people's teeth. And we do it. We're like the bone specialists. So I'm like, I've been the bone specialist for like my whole life. This is my goal, is to save bone. Because if I save bone, I save people's teeth. But here I am, a hygienist I have 3 molars and class 1 furcation, and I have no bleeding on probing. So when you have that patient that comes in, that is the A plus patient, that is losing pretty much horizontal bone, like they're just going to lose horizontal bone,
Mm-hmm.
and you have no clue, there's no bleeding on probing, and they are the best patient you have. They're doing everything. I mean, look at me, I'm a hygienist. I've had no bleeding on probing, and I'm in class. On 4 of my molars, I have class 1 furcation. Now, when we get to that point where I was like, what am I doing? I must be clinching and grinding. I must be brushing too hard, all these little things. No, I had severe osteoporosis. Like that should have been a sign. And another sign is back pain and a rounded posture. Hello, that's hygienist.
Yeah,
So
it is.
I am just really passionate about this. I want to see if I can even link it to possibility of toxicities around dental, radiation around dental. Those are all things that impact our bones with the aerosols of mercury. Like, I don't know what it is, but there's got to be a little bit of a connection also, because we're seeing more and more and more women that are struggling. And I think there's a lot of hygienists out there that have no idea that they have it.
Yeah. And, or that these particular patients, like what you mentioned, I can't even tell you how many patients I have seen that are meticulous with their hygiene. There's no plaque, there's no bleeding. And yet every time it's like their gums and their bone is just going down and down. So now when I have patients like that, I'm going to have a conversation with them about osteoporosis. Yeah. So thank you for
Absolutely.
that.
That makes me, this is why I'm here, is because I want this to happen. And don't just think of women. Remember, we
Yeah.
have men. So I had an older gentleman come in the other day, and he is meticulous too. Looks great. No bleeding on probing. And he had had some recession, additional recession. And he's thinner. He's fit, but he's thin. And I just was like, I don't know. It may be worth having that checked out. What would it hurt to go and have something looked at? And that's the thing, is I don't think it really should hurt. it should be something that we want to do. And it should be something that, I want early screening. I want to have it. I want people to think about their bone health right now. And that means getting to me, I want to change the world with early screening for systemic conditions. And one of them is the bone health. And I think every single person should have a baseline at 30 years old. I don't even know my baseline. I mean, I know now what it is and it's horrible. I know what I am now, but like, where did I start at 30? And then could we manage it and watch it similar to a mammogram? We look at those all the time and we take them regularly and we say, well, this is a screening and we're going to see if there's any changes. Well, why would we not do a baseline with that and have it at 30 years old? Everybody has a baseline. Where are you at? And then we monitor and see so that we can see, are you progressing faster than you should be? Do we need to do different things? So that's where really I am. And it does not start when you're 50 years old. Now, right now, the recommendation is 65. Like if I would have waited till I was 65 years old, I would have been broken. And that's where most of the osteoporosis diagnosis are coming in, is a fracture. So someone gets fractured and then they're like, oh yeah, you have osteoporosis. It's like, oh no, now I'm in trouble because I had the fracture. We can do this in dentistry. I'm on the edge of, or about to start with a university on some study, being an adjunct of faculty. I'm super passionate about this. I want to do a bunch of research to see where we can do this in dentistry, but we are the ones that see our patients most often than any other healthcare provider. We can be powerful healthcare providers because we see them more often. We can manage inflammatory conditions. Our x-rays, you guys, CBCT scanning is going to be the top way of finding bone health. I am so excited about cone beams. Like that is where my research hopefully is going to come from, is we're looking at the cone beam x-ray, being able to decipher and see how bone health is, and to be able to maybe use that as early screening instead of going for the full body x-ray again with the DEXA scan, because the DEXA scan is a full body x-ray. So we're putting more radiation in.
I was
No,
just
go
going to
ahead.
go back to the DEXA scan because you
Mhm.
mentioned it's not recommended. I'm sure it's not covered by insurance until you hit 65, which for many people is too late. So it's really important for us to just advocate for ourselves, right? And make
Yeah.
sure that we get that, even if we have to pay out of pocket. Like if I wanted a DEXA scan, I'm 42. How would I go about getting that?
Yeah, so this would be something that you would need to talk to your physician because you have to have that. So you got to get a good
Okay.
physician. Many times, if you have higher risk, so if you're in the higher risk factor, by the way, thin white is high risk. And anyone that started to go into perimenopause, that was a key sign that I should have known that I didn't, is that I started perimenopause in my early 40s. And so once you start into that, you're starting to have hormone fluctuations that may not be sustainable for bone health. And so we need to make sure that we are talking to our patients. People that have PCOS are more at risk, people with diabetes. So we're talking in your 20s. So if you have a higher risk factor, if you have any family members, you have a mama, grandma, if you have anybody that has it, my daughter's at severe risk. My two boys are at risk for it because me being osteoporosis, they are more likely to have it too. And so this is all things that we have to be thinking about. 65 is unfortunately what most primary care physicians will then recommend their patient take it because it's a recommendation. They're starting now to say, hey, we should do that earlier. My insurance actually covered it, and I was 52, so, or 53. So it did cover it. So it's absolutely worth checking into. And if not, you may want to look at getting one just yourself. I'm hoping that down the road we can actually start to screen for this with dental. And anyone that has a scan, like a scanner, it's really kind of fun as you scan people's mouths now for the computer generated, like you get this the 3D model of the mouth.
Like a
Um,
iTero scan? Is
yeah,
that
like an
what you
iTero
mean? Okay.
scan. There's so many different ones that are scanning now.
Yeah.
But These scans now are starting to now layer, like you can take one scan and then you can layer that scan on another scan. And I will tell you that then the computer, AI is going to have a huge part in all of this with the CBCT and with these scans. But then the computer then can go in and then it can say like, oh, well, we see that right here you've actually had loss of bone, or your teeth have moved this far. Like moving teeth, shifting teeth, these are great because we can't see those microscopic movements, but the
Hmm.
computer can. And so scans, obviously you're probing. I just know that my probing is never going to be as accurate as a computer scan because I'm kind of guessing again and how hard did I push or this or that.
Right.
So
Yeah.
it's just exciting because dentistry has a big role and we can do this. And I'm super excited about it.
Yeah, especially because you're right, we see our patients so frequently compared to like other medical professionals. But when we're talking about like scans or radiography, whatever, what exactly are we looking at? Like, can we tell from a CBCT, and how do we tell, or from a pano or from a bite wing? Like, what are some things we're looking at?
So one of the things is with the CBCT is I'm super passionate about this too, is that you cannot be the one that does it. This is going to require dental radiologist. And anybody that's excited about being a dental radiologist, it's going to be the future, guys, because these scans are so intricate and technical and they show so many details. Like they can show cancer, they can show calcifications in the arteries, they can show so many different things in the sinuses. So we need to be careful about taking CBCT scans and not having a dental radiologist read them. And I have to say, with AI is going to be the second look or the second opinion. So if we can get AI up and running, which right now 2D is still like they're still working on that and they haven't gotten to 3D yet. So I keep praying. I'm like, please, guys, please, please, I need this. I need this. And they're working really hard at it. But you need to know that AI can be that second eyeball. So when we take a dental x ray, let's say a CBT, the AI would come up and say a possibility of osteoporosis. Then you could refer for a DEXA scan or for a REMS. REMS is an ultrasound of the bone, which isn't very common in very many areas, but it is a great one to do it instead of DEXA scan. So that's where we can do early screening. We will never diagnose that. Dentistry will never diagnose osteoporosis. We are great screeners. We
Yeah.
screen and then get them to the right place. And that's where I find that we have such a power in being able to, the oral signs are always the first signs usually in everything. And then we can combine them with blood work. I'm super excited about salivary testing. We know now that salivary testing can be equal, if not better than blood. So we are going to be the future, and we can move this then into supporting people with referrals. We have to refer, but we have, especially dental hygienists, we have a great opportunity, and I'm excited for it.
Yeah, I think we're at a pretty pivotal point in dentistry on different fronts, as far as like the dental hygiene scope of practice and potentially allowing other people to do our job. That's a whole other conversation. But also
Yes.
this oral systemic and truly practicing prevention. I'm excited too. There's a lot of possibility. Is there something that we can, like if I'm looking at a pano or if I'm looking at a bite wing, is there something that would maybe give me a red flag on that they should have a referral or have a radiologist look at them?
It is hard to see. It can
Okay.
be done. There's clinical studies out there. Actually, there was one study that came out in 1994 that actually said that osteoporosis can be diagnosed in a panoramic x-ray. But you have to do these, like you have to take it and you measure it, and then you have to measure each one and see if the bone is so much, if not on the radius of the bone, usually around the mandible or on the mental foramen. And this is where you usually see the thinning of it. But it's hard. It's a hard area because CBCT is the greatest. Because when they go in and do that 3D, they can actually see the holes. Where a pano is 2D. It just is so flat. We can't always see it. And you're meshing the buccal with the lingual, and you have all the aspects that are really hard. So this right now is probably one of the things that we can't do. If you're taking all the risk factors, you have someone who really has really no disease. They don't have bleeding on probing. They're losing bone. They're thin. They have all the characteristics that I talked about. It's just worth it to send them off to see. Like, it's such an easy thing.
Yeah, and it won't hurt anything, right? It'll just give them some information. And if they don't have it, great. Like one
Yeah.
less thing to worry about.
Well, and if they don't
Um,
have it, now they have a baseline, because
yeah, right.
now they have a baseline of what they are at this point in their life. And then we can manage that from there and say, hey, I still think you should have a DEXA scan every, 2 to 3, maybe 4 years, depending on if you have it or not. If you have osteopenia or osteoporosis, it is recommended every 2 years. And that's what
Okay.
insurance usually covers.
Okay. So, what are some things that we can do just proactively for our bone health, whether or not we have osteoporosis or penia?
So one of the things I wanted to just play a part in and let you know is that, again, I'm very passionate about women's health and menopause. I actually watched your other one on menopause too. I loved it. Estrogen is a major player, you guys. So this is big to understand. It's not in menopause. It's actually perimenopause or before. We need to be monitoring our estrogen. Estrogen is a major contributor for regulating bone remodeling. It absolutely plays a part with the osteoblasts that build the bone and the osteoclasts that actually will take away the bone. And we have to have that. We have to have where we take away the bad bone and we build new bone. Because again, every 10 to 12 years, we're rebuilding our body structure. Calcium absorption is absolutely monitored and aided by estrogen. And also the bone balance with our calcium, keeping that calcium bone balance. And we also, the rebuilding, like I said, of the bone. And estrogen is a big anti-inflammatory. I just never understood the importance of estrogen. And I think we're seeing that unbelievable medical professionals are in women's health. Many of them are women that are now in their 50s that are like, what happened?
Yeah.
And I'm not going to let this happen to anybody else. And that's how I am with osteoporosis is I'm not going to have another 52-year-old have to say they have severe osteoporosis. I think we can do this by really doing a lot more of our preventative. And this plays a part with getting a really great primary care physician or a hormone specialist, somebody that's going to monitor you and is going to help you to have the best future. And hormones are a big part, not just estrogen, insulin, thyroid. All of these things can contribute to heart disease, dementia. We know that estrogen is a big part in all of those because it is a primary hormone that can affect every area of our life. And so it's really important, I think, with that is to get a physician that you're comfortable with, that listens to you, that does the blood work, that knows what they're talking about. It's really hard to find an osteoporosis guy. And I don't have one locally, but I listen to Dr. Doug Lucas. He's somebody I would suggest everyone get on YouTube. He is
Okay.
fabulous. He's a retired orthopedic surgeon and he knows what he's talking about and he is amazing. And so I get a lot of my information from him. Get yourself somebody that's going to help you with that. I also think that we need to make sure that we are the risk factors I already talked about, lowering caffeine, smoking, alcohol, making sure we're getting really good sleep. I'm a big proponent of sleep, nutrition, balanced nutrition, healthy nutrition. I love protein, healthy fats, and fiber. Those are the things that are going to feed our oral microbiome. They're going to feed our gut microbiome. They are going to make us better and they're going to build our muscles. And you guys, it's about your muscles. When our muscles start to go away, then our bones go with it. And so this is a big player is resistance training. And I know there are a lot of people that are like, well, I do so much cardio. And cardio, there's a place for cardio, but they have actually been doing research now of long distance runners. They're testing them for osteoporosis and they have severe osteoporosis because they are getting so lean that their bones are actually lightening up in order to let them be able to go longer. We actually want more muscle when we have more muscle, the bone actually grows with it. And we're learning more and more about longevity is about muscles and keeping those muscles. So resistance training, everybody, like you have to do resistance. I just did it this morning. I lift a
Me
lot of
too.
weights and I try really hard. I have a YouTube that I watch that's free. It's PJ Fitness with PJ, and she's fabulous. And she also protects you against osteoporosis. Like, be careful, don't do this if you have osteoporosis. And vitamin D and lowering stress, those are all things that I want to fight as much as I can. My osteoporosis, I want to fight with all of these things before I have to or need to go on medication. And medications are a risk benefit. You have to have that primary care physician that helps you, that doesn't say just at 54 years old, like, hey, you need to go on a bisphosphonate, because these medications, there's bisphosphonates, there's the injectables like Prolia. We see a lot of our patients that are on these. And these medications are medications that are, again, a risk benefit. They a lot of times cause people, they don't make you feel very good while you're taking them. And they have a lifespan of them, or a predictable span that you're supposed to stay on them from 2 to 5 years. Then you got to go off of them and go on something different. And that comes the problem, is jumping between all these meds to try to keep your osteoporosis from advancing at a very young age means you could run out of medications by the time you're even 70 years old. And
Mm.
so once you stop these medications, or at a point where your body's got is used to them, they actually can rebuild new bone on bad bone, and then the new bone goes away. Unfortunately, the studies are showing that the bone can go away very rapidly after that. And then where are you? So my thing is, if you're old enough that your doctor and you feel like you need to be on medications like bisphosphonates, we do know there's always a risk of osteonecrosis of the jaw, so we need to pay special attention to those. We know that that is going to be something that we need to watch for our patients on. But we also, if that's the only choice and we need to do that, then go on that, but also do the other things that I've talked about, lowering your risk factors, vitamin D, great nutrition. I have a vibration plate I love to use. It helps with the lymphatic system. So there's so many different things. Heel drops are really easy to do to help. There's Dr. Doug Lucas has everything. So just go on his for that. And you need to keep up with a tighter recare for our hygiene visits. These patients need a tighter recare because they have an inflammatory disease. And we need to keep all of the risk factors at bay, and we need to protect them. And I think they'll understand that. They may not have a lot of calculus because they're usually our cleanest patients, but we
Yeah.
still want to monitor and check them and see how things are going, because many of these people will lose teeth. I'm worried about it. Could be a hygienist without, teeth, and that's a total scary thing for a hygienist. We don't want to lose anyone's teeth, but especially our own.
Oh yeah. I had to get a cavity filled recently and I just felt so much shame about that. And I can only imagine, like, if we're talking about tooth loss, that's a big deal for anyone. I really appreciate you bringing up specific exercises. And from what I've learned, it's really good to get into our midlife or head into our midlife and beyond with some meat on our bones. I was raised in, skinnier is better, thinner is better. And I do have some meat on my bone. I've always been a little thicker, but I think that that's going to serve me well as I get into my later years. I'm in perimenopause now, and I know the stats on muscle loss for women. What is it, over 35? We're losing 1% or more of our
Mhm.
muscle every year. Like,
Yeah,
that's crazy to me.
yeah.
Like, what are we going to look like when we're 80 or 90?
Yeah, we don't know that. And that's what is scary, is because we've never had this generation that is not active. The generations before had much more activity. We have much less activity. A lot of
Yeah.
people come home from work and they just sit and they're on their
Yeah.
phone all the time.
Yep.
So we have less activity. We have definitely a hormone issue. And we know inflammatory toxins are inflammatory foods. There are so many things going against us. But one of the things is weight training.
Yep.
And so definitely you need meat on your bones. And you think about it, you get all of your highest peak of bone at 30. So between that, teenage girl, let's say the girl, and it's not just girls, but teenage girl till she's 30, they want to be thin.
Yeah.
So the problem is we have this whole basically social stigma and image that you want to be thin. And so we have, unfortunately, a lot of issues with by the time someone's even 30, they don't even have bones that are going to be thick enough to support them. So I really want this to be proactive and say, hey, we need to be doing weight training. And that doesn't mean you have to look like Arnold Schwarzenegger or anything. I mean,
Right.
weights are amazing and they just make you feel toned. But I will tell you, I've gained 10 pounds and people will be like, I don't want to gain, but I am toned. Like it looks good. Scales are really hard because people like to jump on them and say, oh, like I weigh this much. But you could be skinny and diseased and unhealthy. So it's better to be in an optimal, healthy weight. I feel better than I ever have. And I am thrilled that God helped me find something way before I fractured because, I want to live. And we know that once you've had a major fracture, unfortunately, you're in a whole different ballgame then when you have a major bone fracture. And many times at that point, your body's not even able to heal. It's really the healing part is the hardest part is you don't heal from those. And so there's a lot of other factors. Again, we know those bones just interact with so much.
Yeah.
Um,
And when we're
I was,
talking about
yeah.
aging
Uh-huh.
too, we want to maintain our independence. We want to be able to walk upstairs and get up off of the couch and bring our groceries in. And it's really like what we're doing right now is going to dictate whether or not we're able to do that.
Absolutely. One of the things that we have seen more, and I wanted to talk briefly about it, is the GLP-1 meds.
Yes.
So we have more and more of our patients that are on those. If you listen to Dr. Doug Lucas, just go on and listen. He has great education on GLP-1 meds and what they do to your bones, but it's not necessarily good. GLP-1s definitely play a big part for those that are obese, severe obesity, or struggling with that and diabetes. There's a place for them. The problem is that we have a lot of people using them that probably shouldn't be using them, or they're using them at too high of amount. And when we have rapid bone loss, when we have rapid muscle loss, which is the very first thing GLP-1 meds do, is they lose muscle. You lose a massive amount of muscle. And when you have that, then your bones will go with it. The problem with GLP-1 meds that we as dental professionals need to be aware of, bringing back to the PHRDH, is many of them cause enormous issues with the gut. They influence and hurt the gut, and they cause a lot of reflux. And when we have that, we're going to have acidity in the mouth. So there's a double whammy with that we need to be, as especially dental hygienists and dental professionals, we need to be paying very close attention to our patients that are on the GLP-1 meds, making sure that they don't have these issues because they will start to lose their bone around. We know implant failure, like you're crazy to put an implant in anybody to me that hasn't had a cone beam. And you're crazy to put one in anyone with that is taking a GLP-1 med that needs to have that all worked out first. Make sure their bone's healthy before you do it because we don't want to fail at implants. We don't want to fail at our job either of maintaining bone. And it may be as easy as just getting someone diagnosed.
Yeah. Yeah. Thank you for mentioning that about the GLP ones. Really, whenever we have anyone that has significant rapid weight loss, I mean, they get very excited about it, right? But how much of that is fat and how much of that is muscle? And I think that there's a way to have fat loss without the muscle wasting. And I don't necessarily think that losing, 50 pounds in a month is the best way to do that.
There's a great doctor I follow. He's actually a doctor because he's a scientist, but Dr. Ben Bickman, Bikman, him and Dr. Doug Lucas are my go-tos. But he has a lot about this medication. And he says that research is coming out recently to show that people that lose dramatic amount of weight, either through this or through other kinds of weight loss, fast weight loss, they have a lot of mental health issues with depression
Mm.
and anxiety. And so again, this is something as dental hygienist, it's a big part of my passion is the whole person, is treating them as a whole person, not just their mouth. And so when we have these people that are struggling with anxiety, depression, it's going to influence their inflammatory response. It's going to influence how their system's doing, their sleep, and just so many different things with mental health and their gut. So it's a lot.
It is a lot. And what a huge opportunity for us to better educate and care for our patients. So thank you. You gave us so many like nuggets of information, and I know I learned some new things today. How can people, if they want to reach out to you, what's the best place for that? And how can people learn more?
I love speaking, obviously. So I am open to any speaking. I want to get the word out. My goal is to change the world with early screening for oral and systemic, mainly systemic conditions that we find in our orally. And so I want to change the world to have us be great healthcare providers as dental professionals. Reach me at I have a pretty big thing with LinkedIn. I have a lot of
Mhm.
information on there. And you can also find me at my Gmail account, which is Kristin Evans, RDH at Gmail. So pretty easy, just my name. You can find me there. I'm on Instagram. I don't do a lot of stuff on social media. That's probably a downfall. That's probably my age. But
I don't know if it's a downfall.
I don't
I
know.
have to take
Well,
breaks from it. But yeah, when people tell me they're not on social, I have a certain level of respect for people that do that.
yeah, I would tell you that speaking, unfortunately, a lot of the big events, they want someone with a lot of social media. So I'm letting God give me the opportunities where I need them. But you're totally welcome to reach me that way. I would love anybody that has any questions, please contact me, email. I love to answer and help people. I love when someone writes and says, I need help or I want this. So please reach out to me. But again, you can find me on LinkedIn. I go by, if you do the PHRDH, that actually, I think I'm the only one on Instagram that's that. And so I'm also on LinkedIn with that.
Okay, awesome. Well, I'll make sure to put links for all of that down in the show notes so it's very easy for people to find you. And thank you so much for joining today, Kristin. I really appreciate
Yeah.
your time.
Well, thank you.
All right. And thank you everyone for listening, and we will see you next time.